Good afternoon, everybody. Myself, Dr. Shyamashish, will be presenting my topic on attention deficit and hyperactivity disorder in children. The things we are going to cover are firstly the introduction, basic introduction, diagnostic criteria, epidemiology, etiology, prognosis, and the treatment. Introduction. Attention deficit hyperactivity disorder. None from the synopsis and DSM. Synopsis, Kaplan and Sedok, and DSM. Attention deficit hyperactivity disorder is a neuropsychiatric condition affecting preschoolers, children, adolescents, and adults around the world, which is basically characterized by diminished sustained attention, increased impulsivity, or hyperactivity. ADHD affects up to 5 to 8% of school age children, with 60 to 85% of those diagnosed as children continuing to meet criteria for disorder in adolescence as well, and up to 60% of that continuing to be symptomatic into adulthood. Children, adolescents, and adults with ADHD often have significant impairment in academic functioning as well as social interpersonal situations. ADHD is frequently associated with comorbid disorders, including learning disorders, anxiety disorders, mood disorders, and disruptive behavior disorders. The diagnostic criteria as per as DSM-5. So 5 criteria are essential. Criteria A, which includes 1 and 2. Criteria A1 and A2 are important as they tell us the presentation of diagnosis, which can be combined presentation or can be predominantly inattentive presentation or predominantly hyperactive or impulsive presentation. Criteria A1, which includes inattention as a symptom. 6 or more symptoms persistent for at least 6 months to a degree that is inconsistent with developmental level and negatively impacts on social and academic occupational activities directly. So the 6 or more symptoms should be present for at least 6 months. It can include often the child fails to give close attention to details or makes careless mistakes in schoolwork, at work, or during other activities, has difficulty attaining attention in tasks or play activities. Example, difficulty remaining focused during lectures and conversations. The child doesn't seem to listen when spoken to directly. Example, mind seems elsewhere, doesn't follow through on instructions and fails to finish schoolwork, chores, or duties in workplace. So basically, the child will start the task but will lose focus easily and will be distracted. Has difficulty organizing tasks and activities. Example, difficulty keeping materials and belongings in order, messy disorganized work, poor time management, avoids tasks that require sustained mental effort. Example, schoolwork or homework, and for adolescents and adults, preparing reports and completing reports as well. Loses things necessary for tasks or activities. Example, school materials, pencils, books, and other stationary things as well. Easily distracted by external stimuli. Example, unrelated thoughts. And forgetful in daily activities as well. Criteria A2, which includes hyperactivity and impulsivity as symptoms. So this also requires 6 or more symptoms persisted for at least 6 months, which includes the child or the patient will fidgety or tap hands frequently or feet or squirm in the seats. Leave seat in situations where remaining seated is expected. Example, in classroom, in workplace, etc. Runs about or climbs in situations where it is inappropriate. Unable to play or engage in leisure activities quietly, is often on the go, acting as if driven by a motor. Example, uncomfortable being still for extended time, as in restaurants or meetings. Talks excessively, blurts out an answer before a question has even been completed. Difficulty waiting for his or her turn. Intrudes or interrupts on others as well. So these were the things which were getting covered up in A part of the 5 criteria. The next is B, which is several inattentive or hyperactive impulsive symptoms which were present prior to the age of 12 years. C. Several inattentive or hyperactive impulsive symptoms are present in two or more settings. Example at home, school, or at work, with friends or relatives, and in other activities as well. D. There is clear evidence that the symptoms. Ma'am, we. D. There is clear evidence that the symptoms interfere with or reduce the quality of social, academic, or occupational functioning. And E. The symptoms do not occur exclusively during the course of schizophrenia or any other psychotic disorder, and are not better explained by other mental disorders as well. Example: mood disorder, anxiety disorder, dissociative disorders, personality disorder, or substance intoxication or withdrawal. And it is very important to specify whether we are having a combined presentation, which again suggests that both criteria A1 and A2 of inattention and hyperactivity impulsivity are met for past 6 months. Predominantly inactive inattentive presentation, that criteria A1 is met but A2 is not met for the past 6 months. And predominantly hyperactive or impulsive presentation, in which criteria A2 is met but A1 is not met for the past 6 months. And also we need to specify the severity of the disease, which can be mild, moderate, or severe. Mild, in which the if diagnostic symptoms are present but symptoms result in no more than minor impairments in social or occupational functioning. Moderate, as the name suggests, would range between mild and severe function impairment of social and occupational functioning, and severe in excess of those required to make diagnosis, or several symptoms that are particularly severe are present, or the symptoms result in marked impairment. Epidemiology. Rates of ADHD have been reported to be about 7 to 8% in prepubertal elementary school children, and in about 5% of youth, including children and adolescents, and about 2.5% in adults. And it is also known from the study that the rate of ADHD in parents and siblings of children with ADHD is 2 to 8 times greater than in the general population. ADHD is more prevalent in boys than in girls, with ratio ranging from 2:1 to 9:1. Parents of children with ADHD show an increased incidence of substance use disorders. Epidemiology. Siblings of children with ADHD are also at higher risk than the general population for learning disorders and academic difficulties as well. Symptoms of ADHD are often present by the age of 3 years, but unless they are very severe, the diagnosis is frequently not made until the child is in kindergarten or elementary school, when the teacher information is available comparing the index child peers of the same age. Etiology. So the data basically suggests that etiology is large. The etiology of ADHD is largely genetic with a heritability of approximately 75%. So ADHD symptoms are product of complex interactions of neuroanatomical, neurochemical symptoms as evidenced by data from twin and adoption family genetic studies. Also, there is genetic involvement of dopamine transport gene studies, neuroimaging studies, and neurotransmitter data. Yes, ma'am, it suggests genetic factors, the positive association of ADHD with dopamine transporter gene 1 and dopamine 4 receptor 7 repeat allele gene. Neurochemical factors, many neurotransmitters are postulated to be associated with ADHD symptoms. However, dopamine is the major focus of clinical investigation, and the prefrontal cortex has been implicated based on its role in attention and regulation of impulse control. It also suggests that the hypothesis regarding that the neurochemistry of ADHD have arisen basically from the predictable effects of ADHD. Stimulants known to be the most effective medications of treatment of ADHD, so affect basically both dopamine, ma'am, dopamine and norepinephrine. Stimulants, ma'am, we use methylphenidate and methylphenidate, more non-stimulant. Ma'am, and amphetamines. Amphetamines. Yeah. Affect both dopamine and norepinephrine. So, as it suggests, the dopamine system efficacy of stimulant medication in treatment of ADHD suggests that the medications may affect brain systems involving catecholamines. Stimulant drugs bind strongly to dopamine receptor, dopamine transporter, and compete with the dopamine molecules at the dopamine transporter site to prevent reuptake of dopamine back into the presynaptic zone for metabolism. PET scans in adults have also supported the same. Noradrenergic system, child with ADHD show inattention, cognitive deficits, and higher levels of gross motor activities. So, in this also dysfunction in the brain of norepinephrine systems, particularly a lack of inhibition of locus ceruleus neurons could explain these clinical findings. Norepinephrine. Locus ceruleus. and and the neurophysiological factors as well. Like EEG studies have reported that there is increased theta activities, especially in the frontal regions, and neuroanatomical factors, which suggest that the correlations for the superior and temporal cortices are generally related with focusing attention, external parietal and corpus striatal regions with motor executive functions, and hippocampus with encoding of memory traces, and prefrontal cortex with shifting from one stimulus to another, which basically leads to complaint of inattention. Developmental factors as well, higher rates of higher rates of ADHD are present in children who were born prematurely and whose mothers were observed to have a maternal infection during pregnancy. Factors as well. Severe chronic abuse, maltreatment, neglect are associated with certain behavioral symptoms that overlap with the ADHD, including poor attention and poor impulse control. And environmental factors as well, like high lead exposure and maternal smoking, are also associated. Prognosis. The course of ADHD is variable. So in basically it says that it tends to persist into adolescence in about 60 to 85% of cases, and in adult life in also about 60% of cases. The remaining 40% of cases may remit at puberty or in early adulthood. In some cases, hyperactivity may disappear, but the decreased attention span and impulse control problems still persist. Overactivity is usually the first complaint to remit, and distractibility is the last. When remission occurs, it usually occurs between the age of 12 and 20. It is generally accompanied by the productive adolescence and adult life. satisfying interpersonal relationships, and few significant sequelae. Most patients with the disorder, however, undergo partial remission and are vulnerable to antisocial behavior, substance use disorders, and mood disorders. In about 60% of cases, some symptoms persist into adulthood. Those who persist with the disorder, may show diminished hyperactivity but remain impulsive and accident prone. Children with both ADHD and conduct disorders are also at risk of developing substance use disorders as well. The development of substance use disorders among ADHD is in youth and adolescent appears to be more related to the presence of conduct disorders as well, more than ADHD. Most children with ADHD have some social difficulties. Socially dysfunctional children with ADHD have significantly higher rates of comorbid psychiatric disorders and experience more problems with behavior in school as well as with peers and family members. Overall, the outcome of ADHD in children is related to the degree of persistent comorbid psychopathology, especially conduct disorder, social disability, and chaotic family factors as well. Treatment is basically of two types, pharmacotherapy and non-pharmacological treatment. So pharmacotherapy is the first line of treatment, which basically involves CNS stimulants drugs which are the first choice of agents in which they have shown to have greatest efficacy. Current strategies favor once a day sustained release stimulant preparations. Advantages of this sustained release preparations for children are that one dose in the morning will sustain the effects all day, and the child is no longer required to interrupt his or her school day, as well as the physiological advantage that the medication is sustained at an approximately even level in the body throughout the day, so the periods of rebound and irritability will be less. Pharmacotherapy so basically involves two kinds of drugs, stimulant medications and non-stimulant. Stimulant medications involves methylphenidate or amphetamine preparations, and non-stimulant medications for ADHD would be atomoxetine or bupropion preparations or alpha-adrenergic drugs as well, like clonidine and guaifenesin. And third line for treatment would be if we can use as a combination of the above two and add tricyclic antidepressants as well.